Hi, Jay Widmer reporting from the ACC Mix and Mingle for Fits on the Go blog. As you can see, we're in full swing here with the interventional cardiologist paying close attention.
European cardiologists have access to newer devices sooner than us in the United States. What do you identify as barriers to sooner approval of devices in the United States, and how can we overcome these?
I got it. Well, this has been a critical issue for us, and obviously we'd like to see new technology in the U.S. as early as possible. And it's for several reasons, not the least of which is that we want to have access for our patients to the best technology so that we can reduce complications and improve our clinical outcomes. The FDA regulatory process, some people feel, is truly burdensome. And it's been problematic, and at times it's been overburdensome. I think more recently, and using the example of transcatheter valves, I frankly think that the FDA has been reasonably appropriate in terms of the way it's staged the approval of the various devices, insisting on the first randomized trials ever done. I think now we actually have evidence-based information that has stimulated the field, and I think you're going to see a rapid acceleration of device approvals after those first studies. There's a lot of activation energy that goes into starting those studies, but now I'm seeing the FDA being far more responsive. They approved the core valve extreme risk even without a panel. Now we have another randomized trial with core valve that looks equally exciting, showing a mortality benefit, perhaps, which I'm sure will allow that extension of that indication. We're seeing iterative devices being looked at with really impressive rapidity. In fact, the Sapien 3, which is a next generation device in the balloon expandable arm, has had more cases done in the United States right now than in Europe so far. So I think that we're beginning to take the pendulum back, and with the FDA early feasibility program, we expect to be initiating a lot of early stage investigation in the US that previously had been done elsewhere. So I think that that over-regulated stigma that we've been attached to with the FDA is being softened.
Some leading cardiologists have advocated the replacement of the physical exam with training in ultrasound devices, particularly portable ultrasound devices. And Dr. Bonow, I was wondering how you would respond to people who strongly advocate such a move.
Well, I think it depends on whether we're talking about training cardiologists or training internists. I mean, it's been advocated that maybe we should throw away the stethoscope and every medical resident learns how to do a handheld echo. And there's just no way a resident's going to learn all the ins and outs and foibles of ultrasound imaging while he or she is trying to learn to be a doctor at the same time. So that's a separate issue than whether cardiology fellows. I think the handheld echo has great potential for all of us as we're evaluating our patients. But I still think there's some things about the physical exam that are very, very important. First of all, I think our patients want that still. Now, maybe in the future they won't, but I think they still want the hands-on approach, listening, carefully examining, and coming up with a conclusion. Whether we do the echo the usual way or a handheld way is going to be very powerful, no doubt about it. And probably in the future, we will go there. What we need is probably a good trial where we randomize fellows to learning physical exams, which is a dying art, to doing handheld echo. I mean, think of Star Trek, where they take that wand and they beam it up and down the body and they get the answer. Well, that's the way it's going to be at some point in time. It may not be an echo, it'll be something else, but getting from here to there, I think, is going to take a couple steps, including maybe even some research to see that they wind up with better training and better patient outcomes.